ただいまご紹介に預かりました中谷弘樹でございます。どうぞよろしくお願いいたします。基調講演では3名の世界的に著名な先生方にご講演をいただきます。まず第1席が世界医師会元会長、ユニバーシティカレッジロンドン疫学教授サー・マイケル・マーモット先生でございます。先生、どうぞ演題をお進みください。その間に先生のご業績など若干ご説明を申し上げます。先生は長年にわたる健康の社会的決定要因に関する疫学研究のご功績が称えられまして、2000年にエリザベス女王陛下からサーの称号が授与されておられます。先生はまたイギリス医師会元会長であり、ここにございますヘルスギャップですとか、あるいはステータスシンドロームという著名な著書の著者でもございます。本日は社会正義と保健政策と題しましてご講演をいただきます。それではマーモット先生、どうぞよろしくお願いいたします。Sir Mahmoud, please.
Thank you. And I must say it's a particular pleasure to be part of this celebration of a unique program that the Takemi program is. And it has, I'm sure, made a major contribution to health policy, and indeed to friendly relations around the world. So congratulations, sir. For those of you who heard me speak yesterday, I've got a test. You have to tell which slides I'm showing today that I showed yesterday. And I'm going to do a test afterwards to see if you were listening. Admittedly, I was after lunch yesterday, so that was a challenge. Let me help you. I did show this one yesterday. The theme is universal health coverage of today, but everything I do is about social determinants of health. My question at the start of the health gap was why treat people and send them back to the conditions that made them sick. What I want to do briefly is sketch out some of the conditions that make people sick, but then show how there's no contradiction between emphasizing the social determinants of health and encouraging good medical practice to take account of these social determinants and how that can be done. My starting point, as always, is the social gradient. When we think about inequalities in health, commonly we think about poor health for the poor. I showed yesterday data from Taiwan showing that there was a social gradient in Taiwan. These are data from England. Every dot here represents a local authority, a small area of the country, a neighborhood, classified by degree of deprivation. So to the right, we have the least deprived. To the left, as you look at it, the most deprived. The top graph is life expectancy. And what it shows is that people near the top have shorter life expectancy than those at the top. People in the middle have shorter life expectancy than those near the top, all the way from top to bottom. And we have a national health service with universal health coverage. Everybody has access to health care free at the point of use. People near the top don't have shorter life expectancy than those at the top because they can't afford to purchase medical care or they somehow don't get access. Everyone has access. And the evidence shows this social gradient in health is not about differential access to health care. It's about unequal conditions in which people are born, grow, live, work, and age. The social determinants of health. Now, if in a rich society we have gradients like this, and they follow social and economic inequalities in society, well, all societies have social and economic inequalities. Japan has social and economic inequalities, and indeed health follows the social gradient in Japan. Does that mean there's nothing we can do about it? Well, the evidence suggests that's untrue. There are things we can do. This is looking at European data, life expectancy at age 25 by education. ISC, the International Social Classification of Education, 0 to 2 is primary education, 5 to 6 is tertiary education. So here's life expectancy at 25 in Sweden. SE is Sweden. And you can see that those with tertiary education have longer life expectancy at 25 than those with primary education. And that's true for every country in this comparison. Here, the countries, the former communist countries of Central and Eastern Europe, Estonia, Hungary, Romania, Bulgaria, Poland, Croatia, the Czech Republic, the inequalities are much bigger than they are in Sweden, Italy, Norway. That means that all societies have social and economic inequalities, and all societies have health inequalities, but the magnitude varies. Another way of looking at these data is that the between-country differences are much smaller for people with university education. They do know how to get good health in Estonia, Hungary, Romania, and Bulgaria, because people with university education get good health. The disadvantage of living in these countries is much bigger if you have only primary education. The disadvantage of having primary education only is much smaller in Sweden, Norway, Italy, than it is in Estonia, Hungary, and Romania. So we can change these inequalities, the social gradient. And the problem is not only, as I said, with the poorest in society. These data from different countries looking at all-cause mortality, ages 45 to 54, from 1990 to 2012, show mortality coming down in France, Germany, the UK, Canada, Australia, Sweden, and US Hispanics. But among US non-Hispanic whites, the mortality was rising. And it was rising, number one, because of poisonings due to drugs and alcohol. Now, I said these are not health care issues, although in this case, overprescription of opioids, the doctors may have actually caused the problem or contributed to the problem. But that's an insufficient explanation, because there was also, number two, an increase in suicides, and number three, chronic liver disease related to alcohol. And Case and Angus Deaton, who produced this paper and did a follow-up 2 years later, calls this deaths of despair. And the despair is not at lack of health insurance. The despair is what's going on in society. And if we look at who died and look at quartiles of mortality of drug, alcohol, and suicide, and take the industrial Midwest in the US, the higher the mortality from drugs, alcohol, and suicide, the greater the likelihood of voting for Donald Trump. Now, I don't think Trump caused deaths from suicide. In fact, I'd like to think that the people who committed suicide didn't vote in the election, although that might be problematic if they did. I don't think Trump caused these deaths, but at some way of thinking, these deaths caused Trump. The kind of dissatisfaction that led people to take their own lives, poison themselves with drugs and alcohol, may well have led to voting for Donald Trump. And we can see this. These are quartiles of economic distress. The greater the economic distress, the greater the likelihood of voting for Trump. So these were disaffected, white men and women left behind by globalization, who killed themselves, poisoned themselves, drank too much alcohol, and voted for Donald Trump. It shows that these kinds of problems, and You can see, as an apolitical person, I think voting for Donald Trump is a problem. This is not the right sort of person to occupy that important position. And these kinds of problems are related to health, and they're related to the political fortunes of society. And when we're sticking with the US for a moment, look at what's been happening to life expectancy by year of birth. So this is life expectancy at age 50 for people who were born in 1920. So this is in the 1970s on, and the 2000s on. And for the richest 10%, life expectancy at age 50 has been going up, but much less for the poorest 10%. So the gradient has got much steeper. These are men, and this is women. For the poorest 10%, going down, and the next 10% going down, and the next one going down. So the gradient's got dramatically steeper. Things are getting worse for these people. Life expectancy tells us how well the society is meeting the needs of its citizens, and it's failing its citizens. That's why health inequalities are increasing, and that's why people are disaffected, and that will affect the whole nature of society. So what are we going to do? What are good doctors going to do? They're going to tell people to behave better so they don't get sick. Our former chief medical officer had 10 top tips for better health. Don't smoke, balanced diet, physically active, manage stress by talking things through, drink alcohol in moderation, cover up in the sun, practice safe sex, take up cancer screening, be safe on the roads, and learn first aid. So, sound science, all very sensible, and totally useless. Completely and utterly useless. Suppose you're a young man and you've been drinking and you're about to drink and drive and have unsafe sex, and then you say, I remember the chief medical officer's advice. I won't do that. I'll call my grandma instead. Well, it's totally useless. Now, here's an alternate 10 top tips for health. Don't be poor. If you can, stop. If you can't, try not to be poor for long. Don't live in a deprived area. If you do move, be able to afford to own a car. Don't work in a stressful job. Don't live in damp, low-quality housing. Be able to afford to go on an annual holiday. Don't be a lone parent. Claim all your benefits. It's also totally useless. It's based on sound science, but people can't do this for themselves. Society needs to do this. Society needs to make sure that people have enough money to live on, that they don't live in damp, unsafe housing. And society needs to take action on the first set. So if we look at tobacco use by men and women in India, by wealth, you can see that the lowest wealth level, much more likely to smoke, and there's a social gradient. And simply to blame poor individuals for smoking is to miss the social pattern. The poorer they are, the more likely to smoke. It's true in India, as it is in the United States or the United Kingdom and most of Europe. We can't simply blame individuals. We've got to ask, what is it about being lower in the social hierarchy that leads people to smoke and to be obese? 19 EU member states, obesity prevalence. It's clearer for women than for men, but it's a very clear gradient. The lower the educational level, the higher the level of obesity. And in childhood, we see it happening already. These are data for 10 to 11-year-olds, children in year 6 at school in England. Least deprived, most deprived. There's a remarkable gradient. The more deprived, the higher the prevalence of childhood obesity. And then what we see, comparing years from 2006-7 to 2012-13, the rise in childhood obesity has leveled off. It's not going up in children from the most affluent backgrounds, but in children from the most deprived backgrounds, it's still increasing. So the inequalities in childhood obesity are increasing. Childhood obesity tracks into adulthood. It means the inequalities in adult obesity are going to increase. And you know, as doctors, universal health coverage coming down the road will be increasing levels of obesity, diabetes, cardiovascular disease, arthritis that follow. And we have to start with prevention, but if you want to do something about obesity, you've got to do something about inequalities. Index of multiple deprivation and the density of fast food outlets in England, McDonald's, Burger King, KFC, and Pizza Hut, the more deprived the area, the greater the density of fast food outlets. So the availability of unhealthy food is greater in deprived areas. And we know in England that the fast food chains that are located near schools are correlated with higher childhood obesity. And if we look at adult obesity in selected countries, Egypt, BMI greater than 30, women in Egypt, 38% obese, USA, 36%, Mexico, 34%. It's not just a rich world problem anymore. Middle-income countries, these high levels of obesity. And if you look at soda market sales, Latin America, the soft drink companies love Latin America. The sales are going up. Mexico now leads the world in Coca-Cola sales, 670 8-ounce portions per person per year, nearly 2 a day. I said that if the babies aren't having Coca-Cola, that means older kids will have to have more than 2 a day. And I was told the babies are having Coca-Cola. It's being put in the bottles. And Mexico has this astonishing high level of obesity. We're not going to deal with that simply by telling people to behave well. We've got to look at the environment that promotes obesity. And to deal with inequalities, my English review, the Marmot review, I had 6 domains of recommendations. Give every child the best start in life, education, fair employment and good working conditions, healthy standard of living for all, healthy and sustainable places to live and work, and taking an approach to prevention along the lines that I've just been discussing. I've tried to get doctors involved in these issues. I said at the beginning I wanted to try and bring social determinants of health and universal health coverage together. And I spent the year as president of the WMA, 2015 to 2016. I didn't have a nice party like the one we had last night when I became president, but that's another story. And my 2 messages to the doctors as part of the World Medical Association was evidence-based policy presented in a spirit of social justice. We said on the cover of the report of the Commission on Social Determinants of Health, social injustice is killing on a grand scale. I was in Washington, D.C. for a meeting of our new Commission on Equity and Health Inequalities in the Americas, and I went for a walk in the mall. And I found myself in the area devoted to Martin Luther King. And there was this quote from Martin Luther King saying, "I believe that unarmed truth and unconditional love." And I thought, unarmed truth? Yeah, that's a nicer way of saying evidence-based policy. Unconditional love? Well, a spirit of social justice Dr. King said it better than I, but same message. I believe that unarmed truth and unconditional love will have the final word in reality. That is why right, temporarily defeated, is stronger than evil triumphant. There's a lot of evil in the world today, but we have to believe with Martin Luther King that right, temporarily defeated, is stronger than evil triumphant. And so my mission for WMA presidency and for my life is health equity through action on the social determinants of health. I reminded them of the message in my book. And I had 3 aims for my year: to get a declaration on social determinants of health, networking, and training. We did get a declaration of Oslo on social determinants of health. We produced a book online on what doctors can do on health equity. So when they ask the question, well, okay, we've got this declaration, but what can we do? We produced this book, and we said there were 5 areas: education and training, working with individuals and communities, the health sector as employer, working in partnership, and the workforce as advocates. I was invited to Australia to give some lectures for the ABC, the Australian Broadcasting Commission, and the Australian Medical Association, people that I'd met through the WMA, wrote to me and said, how can we help? And I said, I would like to see doctors in action on the social determinants of health. What can you show me? Well, they're very concerned in Australia about the gap in health between Indigenous and non-Indigenous people, Australian Aboriginals and Torres Strait Islanders and the non-Indigenous population. 10.6-year gap in life expectancy for men, 9.4 years for women. And they said to me when I arrived, we have spent billions of dollars trying to reduce the health gap, and nothing's worked. So the AMA, the Australian Medical Association doctors, took me to an Aboriginal community centre 50 kilometres south of Sydney, the Tharawal Aboriginal Corporation. They have doctors there. And the different centres in this centre, the belly cast program. Aboriginal women commonly do not attend antenatal classes. The way they got them to attend was to get Aboriginal pregnant women to take plaster casts of their pregnant torsos and then decorate them with Aboriginal art. Absolutely lovely. And the women love it. And they come. And they come to antenatal classes, and they get involved before pregnancy, during pregnancy, and after the birth of the baby. So it's doing something that's culturally relevant, and the women love it, and they get involved. They have legal services, a Department of Housing, disability support, and the children. At the time that I was there, the little children were just being put down to sleep for their afternoon nap. And I said to the young woman who was caring for these children, how do you know if they're developing normally? And she took a stack of forms off the shelf, one for each child, with 30 indicators of cognitive, linguistic, social, emotional, and behavioral development. So where did you get these from? She said, from the university, up to the minute, and monitoring how well these children were developing. The older children, the Deadly Homework Club, every family participates one of these programs that have been evaluated by randomized controlled trials and shown to improve parenting and to improve early child development. And the drug and alcohol part of this center, the woman who was looking after it, these were all Aboriginal women who were running this place. The woman who was looking after it, I said to her, you must have the most difficult job in this whole center. And she said, no, I have the most rewarding job in this whole center. And she took me over to a wall and showed me an Aboriginal painting. She said, the man who did that, when he came here, he had all the problems of drug abuse, alcohol abuse, domestic violence. And we helped him put his life back together. And he came back, he'd done this painting as a gift to us for helping him. I, she said, have the most rewarding job in this whole centre. They have subsidised fruit and vegetables, good tucker all round, and they involve older people. Don't know if you can see this, grannies against removal. There had been a vogue in Australia for removing Aboriginal children from their families and trying to breed the Aboriginal out of them, to bring them up white. It was a disaster for the families and for the children. And these older women, grannies against removal, don't take our children away. And the workforce as advocates. On networking, one of the questions with this whole message on social determinants of health is, who's listening? And when I became president, I said to Dr. Kloiber, as president, I am not going to go to meetings simply because the president normally goes to those meetings. I'm only going to go to places where they want me to talk about my message. So I'm going to be very selective. And I was indeed very selective. I only went to these 25 places. But these were all places who wanted to hear about the social determinants of health message. I tapped into a well of enthusiasm among doctors to get engaged with improving the lives of their patients that make them sick in the first place. Not just to treat the illness in front of them, but to treat the conditions that made them sick. Coventry is a marmot city that's in England. It's taken my messages and trying to implement them. This is not my son, it's the Minister of Health in Sweden. And there are 10 marmot reviews in different parts of Sweden, including a national review. And I mentioned the Commission on Equity and Health Inequalities in the Americas, going from the north of Canada to Tierra del Fuego. We're concerned with the whole of the Americas. Let me finish. I mentioned that the ABC had invited me to give some radio lectures. And to trail the lectures, I was on their public affairs television program. The moderator asked me to talk about income inequalities. And so I said, what do the 48 million people who make up the population of Tanzania have in common with the 7 million people who make up the population of Paraguay, the 2 million people who make up the population of Latvia, and the top 25 earning hedge fund managers in New York? And the answer is, the previous year, each of those groups had an income of about $25 billion. So I said, imagine the hedge fund managers gave up their income for 1 year. They earn $1 billion each on average. They wouldn't miss it because they're going to earn $1 billion each the next year. And we transferred that $25 billion to Tanzania. We double the per capita income. And suppose we said, okay, we're not going to just give it to individual Tanzanians, but imagine the clean water that could be piped to villages, the environmental friendly cook stoves that could be provided, the teachers and nurses. And suppose the hedge fund managers said, we could not care less about Tanzania, we're not going to do it. I said, here's an even more fanciful thought experiment. Suppose they paid 1/3 of their income in tax. I know, completely outlandish. You and I pay 1/3 of our income in tax, but not hedge fund managers. But suppose they paid 1/3 of their income in tax. You could employ 90,000 New York school teachers. And somebody else on the panel said, You're in fantasy land, mate. You're in complete fantasy land. I was a bit stunned by that. I managed to say, Haftan Mahler, the legendary Director General of WHO, said the idealists of today are the realists of tomorrow. But when I went to the Tharawal Community Centre the next day, the doctors who had listened to this program greeted me with a sign saying, "Welcome to Fantasyland." So my greeting to you is welcome to my fantasy land, where we dream of a fairer world. Thank you.
マーモット先生、ありがとうございました。衝撃的とも言えるようなデータを示されまして、ソーシャルディターミナント・オブ・ヘルスの重要性を指摘され、また医師はじめ我々の進むべき道をお示しいただきまして、素晴らしい講演でございました。今一度感謝の拍手を申し上げたいと思います。